Well, good morning, everybody. I'm Carolyn Aldeje, known to many of you as Bo, and I'm the president and CEO of the Prevent Cancer Foundation. It's my sincere honor to welcome you to the 18th annual Quantitative Imaging Workshop. This event is hosted by the Prevent Cancer Foundation, and this year we're thrilled to be presenting the workshop for the second year in a row in partnership with the American Lung Association. As a public health organization, the foundation prioritizes the health and safety of our staff, volunteers, and participants. That's why, for the second year in a row, we're convening this meeting virtually to keep everyone as distant and safe as possible as we continue to navigate the COVID-19 pandemic. But as we explore the science and how we can better optimize imaging for lung health, I'd be remiss if we didn't acknowledge that COVID-19 is primarily a disease of the lungs, and to say how grateful we are to all the scientists, researchers, and healthcare workers who've been working diligently against this disease, whether on vaccinations, on treatments, or on the front lines to keep us all safe and healthy. It is our deepest hope that next year it will be safe for us to once again gather in person for this meeting, and we are indeed planning for that in-person event already. Before we get started, there are a few people I want to thank. Our steering committee works tirelessly throughout the year to bring this meeting to life. They are from a range of disciplines, institutions, and geographic areas, and each brings a unique perspective and expertise to the table. The group is led by Dr. Jim Mulshine, who's also the scientific director of the Prevent Cancer Foundation. Jim guides our group with his years of research experience, backed up by his unwavering passion for lung cancer screening. Also on the committee, we have Rick Avila, Raul San Jose Estepar, Anita McLaughlin, Bruce Pyenson, Al Rizzo, and David Yankelowitz. Thank you to each of you for your invaluable work and contributions. I'd also like to thank our sponsors, without whom the workshop would not be possible. Once again, we're grateful to our partner and gold sponsor, the American Lung Association. We also thank our silver sponsors, Lung Cancer Initiative at Johnson & Johnson and Median Technologies, as well as the International Association for the Study of Lung Cancer for their endorsement. We thought that was critically important. And our many bronze sponsors, supporters, and friends. And last but not least, I'd like to thank our incredibly dedicated staff. Special thanks to Adrian Harkness, Senior Manager of Community Education and Conference Planning, who heads up this event and makes sure nothing falls through the cracks. And Liz Hall, our conference consultant, who keeps us all in line. I'd also like to thank Jody Hoyos, our president and COO. Without Jody, I don't know that this meeting would be happening, because her technical support is what helped get us all ready to be able to present to you today. Karen Peterson, our Vice President of Programs, Lisa Berry Edwards, who heads up communications, Becca Gins, Senior Director of Corporate and Foundation Relations, and Sarah Mahoney, who created all the beautiful graphics you'll be seeing on the screen. I hope all of you tuning in today will continue to keep in touch with the foundation throughout the year, not just for 2 days in November. You can find us on LinkedIn, Facebook, Twitter, Instagram, Discord, and TikTok. You'll also receive a brief survey after the event where you can share your thoughts to help us make next year's quantitative imaging workshop even better. Now I'd like to turn it over to my friend, Dr. Jim Mulshine. Dr. Mulshine is a professor at Rush University, where he has served as Associate Provost and Vice President for Research, as well as Acting Dean of the Graduate College. Prior to joining Rush University, Dr. Mulshine was at the National Cancer Institute for 25 years, where he was on the research faculty. Dr. Melshon is an international expert on lung cancer, and we are humbled and proud to have him as the scientific director of the Prevent Cancer Foundation and as the leader of this meeting. Please welcome our fearless leader, Dr. Jim Melshon. Thank you.
Bo, thank you for your kind words. And I'm humbled by your introduction. This is a wonderful event. We have had the privilege of convening over the last 18 years. It's the 18th of this annual series. And it has been hosted by the Prevent Cancer Foundation throughout this entire time. And I want to thank the foundation, its leaders, and its board for this this commitment, because the things that we talk about are very future directed. There's not a lot of product development opportunities with doing this kind of activity. It's intensely interdisciplinary, it's challenging, and they have been unstinting in their support and very gracious in helping us through this. This is an event that was first conceptualized by my colleagues on the steering committee, Dr. David Yankelevitz and Rick Avila, along with a gentleman, Dr. Stefan Schaller, who was at Siemens at the time, when back in 2003, 2004, we were talking about how do we move along the possibility of quantitative measurements in the course of thoracic disease of the lung. And it was because of their vision that we're here today. And over the ensuing 18 years with Bo's support and Jody's support, the steering committee's commitment, we've been able to accomplish a number of things. And included in your material is the publications that outline the trajectory of this activity over the last 18 years. And I would encourage you in your spare time to take a look at that. And hopefully we'll be adding to that legacy this year. Now, if I could have my slides, please. Thank you very much. Before I jump in, I just want to echo Bo's thanks to the sponsors for this meeting. This is a evolving area, and so it is much more challenging for the kind of support that we typically expect for these types of meetings. And so the brave corporations that are helping us and foundations and associations are very appreciated. And so with that, I'd like to jump into an overview of this workshop, which we have called Optimizing Thoracic Imaging to Detect and Manage Early Lung Cancer / COPD. And so this overview is on that title as it relates to improving health outcomes. Next slide, please. So the goals of this workshop are related here. We'd like to review the status of where we are in terms of detecting and managing early tobacco-related disease through lung cancer screening with the thoracic CT. We want to explore how the social determinants of disease can help, in a sense, morph cancer screening from an early cancer detection process into a more personal-centric health check. And we want to use physical activity, as you'll hear shortly, as an example of a very important health intervention that could be an integral part of this process. We want to define strategies for sustained screening uptake as we move into population health. We want to develop reliable, accessible imaging and related computational tools for early thoracic disease. And to do this, we need well-characterized imaging data with clinical follow-up, as we'll be discussing. We want to define process for analysis and reporting tools to guide the management of early thoracic disease. And we want to start with this intersection between lung cancer and COPD, which will be heavily focused on in the next couple of days. And then we want to potentially define technical approaches for the precise measurements of relevant imaging signatures within the context of lung cancer and COPD. And that'll become more evident as we move through the workshop. Next slide, please. So where do we stand today? This slide attempts to get at the screening context that we're currently facing. And much of this comes from a invited editorial that I had the privilege of publishing with Bruce Pyenson, one of our steering committee members, last week in JAMA Oncology. And so I think, as many are aware, national lung cancer screening implementation is growing in acceptance, and we'll talk about that. But right now, from the published literature, the uptake is somewhere between 6%. Some reports show it slightly higher, some as high as 15% of the target population that is eligible for this under the current CMS national coverage decision. Recently, we had a U.S. Preventive Services Task Force reevaluation of lung cancer screening, as it does its periodic updates. And again, U.S. Preventive Services Task Force endorsed lung cancer screening as with a B score, which means that it has moderate benefit. But in addition to the endorsement, it also expanded the eligibility based in part to the recently published Nelson European screening validation trial, so that it now is proposing that lung cancer screening should begin at age 50 on an annual basis. And it reduces the tobacco exposure to 20 plus pack years as opposed to 30 plus pack years. And so with that, it expands considerably the eligibility for this service, and we'll talk about that. And with this expanded eligibility, we have close to 1,000 screening centers coming online in the last year or so, last several years. And the interesting thing about this is that in order to manage their screening subjects, in general, they're adapting existing general tools to support the specific screening needs, i.e. there's not a cassette of tailored tools that have been developed specifically for screening that are generally accepted. It's kind of a developmental effort right now. And often these data from many sites are captured on generic spreadsheets. And this is a challenge because the SysNet modeling of the new expanded population to get screening shows that that kind of expansion of eligibility will still be cost effective, so that we can afford to do that. But one of the challenges will be, do we have the workforce and do we have the tools to do this in a comfortable, sustainable, high quality kind of way? And again, relative to this, the techniques for more relevant medical information being extracted from thoracic CTs is emerging. And we're going to be talking heavily about COPD, but there's a parallel literature that's also just suggesting that coronary artery disease can be assessed by thoracic CT relative to coronary calcium deposition within the coronary vasculature. And tools for this are appearing in the literature, and many sites are beginning to use them, but there is no widely available consensus tool to do this kind of analysis in the screening context. And so there's important developmental opportunities. Next slide, please. Now, it's also useful to consider obstacles to lung cancer screening. Now, acceptance of screening benefit was, I would say, over the last several years, one of the most important barriers to lung cancer screening implementation. However, with the primary care community and other health professionals, as well as the public, the impact of the recent publications of the Nelson trial from the Dutch-Belgium group, which I just mentioned previously, which is a randomized trial which appeared in the New England Journal that showed a mortality benefit even larger than the mortality benefit reported with the National Lung Screening Trial, has been published. We've seen a 10-year follow-up report of the National Lung Screening Trial, which documents that the impact of screening in that population was in fact improving the mortality outcome in that cohort, even looking back 10 years. So with this kind of more mature data, there is a sense growing amongst the primary care and the public that this is a very important screening service, which is great. However, we've all been beset, as Bo mentioned, by the impact of the COVID-19 pandemic. And as is well published, the impact in terms of screening rates for all kinds of cancer screening has been profoundly impaired by the impact of the COVID-19. And we're just now beginning to see the receding of COVID concerns as we increase the level of vaccination within our population. So we're going to proceed with this workshop with the assumption that COVID-19 will recede from the public consciousness and will resume interest in screening. Prevent Cancer Foundation has a very important program in this regard about getting back on the books, getting people to re-sign up for their screening exams for all kinds of organ sites. This echoes the message of the director of the Cancer Institute, who has published a couple of high visibility articles about the potential impact of the loss of screening that occurred during the pandemic and what the impact will be in terms of subsequent detection of advanced stage disease. And this is a tragic situation, but we would like to reduce that kind of barrier as much as possible. And I think a lot of things are lining up to improve that as well. However, there are some impediments to screening that are less well recognized, and I'd like to talk about them briefly now. One such thing being the unintended consequences of the CMS shared decision-making requirements for screening eligibility. And I've had the privilege of writing an opinion piece on this with my colleagues, Dr. Yankelevitz and Bruce Pyenson, that was published recently that outlined that this shared decision-making process formed a functional barrier, especially amongst vulnerable populations, where they had challenges in terms of getting to sites, and then the requirements at certain sites that there had to be 2 separate visits in certain segments of the population winds up being very, very difficult because they have to get time off from work, and it is quite problematic, and it causes a certain number of people, which is hard to quantitate, to not access this service. So we're talking with others about potentially modifying that requirement. In addition, Anita McLaughlin and others have been involved with the efforts with the American American College of Radiology, the Thoracic Society, and the GO2 Foundation in a dialogue with CMS about other challenges, including logistics and sorting through the financial and eligibility issues at sites for access to screening services. Again, this has turned out to be much more problematic than initially thought, and the American College of Radiology and others are trying to simplify this barrier as well, so that access to screening will be much more fluid and will be available to all segments of our society. In addition, there's concerns that have been recently written about by the U.S. Preventive Services Task Force, as reported in the Journal of the American Medical Association, about structural barriers to equitable care. And this is a major problem that is concerning many. And fortunately, the American Association of Cancer Centers has recently published a white paper on issues with these barriers and efforts to overcome and preserve equitable access to screening service. And that reference, which I show below on the slide, was led by my colleague, Chris Lathan, who's going to help us with Dr. Yankelevitz talk about these big data and equity issues within the context of screening in one of our sessions. Could I have the next slide, please? So a lot of issues about the value of quantitative imaging emerge in discussions about what should we do in this regard. And I have a quote here that could be from a community radiologist that says, I can do very well using lung rads to guide management of lung cancer screening cases. And this is the system based upon mammography management that is developed by the American College of Radiology for breast cancer screening. So it's quite familiar to the community. And so the question for the radiologist is, why should I incur the potential cost and additional effort and time in using quantitative analysis? And so, you know, the steering committee of this workshop is very concerned about potentially communicating the benefits of quantitative imaging. And we have a partial list of these features here. One is from the literature, from the ILCAP group, from the UKLS, from the Nelson group, that quantitative imaging allows for a lower false positivity rate while preserving high sensitivity. In addition, the quantitative imaging also, using the growth rate, allows for an assessment of the clinical aggressiveness or potentially the disease status in certain settings. And then there's going to be quantitative measurement of other signatures of imaging signatures of diseases that are evident in thoracic CT imaging. And I'm going to talk about that in a second in more greater detail. The other issue that's kind of interesting is that to do quantitative imaging, there must be much greater attention to the quality control of the imaging service. And so this is essential for robust quantitative assessment, but we think that this heightened sensitivity to imaging technique and imaging quality might also have spillover benefits in other regards as we move forward in looking at fuller analysis of the thoracic CT images. Next slide, please. So a superb example of the value of reanalysis of thoracic CT emerged in the publication as listed below on this slide from Dr. Steiger, who worked with the international LCAP program in looking at a reanalysis of 52,000 prospective screening subjects for lung cancer screening. Only these were reanalyzed to look at those images for the evidence of COPD, specifically COPD emphysema. And in that analysis of the 52,000 individuals, around 24% of them were found to have some evidence of emphysema, from mild to severe. Overall, about 3/4 of the time, those findings were without any evidence of any kind of understanding of involvement with COPD or with any kind of significant symptomatology. So this is a very important finding. Close to 1/4 of the people have evidence of COPD, and the vast majority of the time in those settings, they had no idea that they had any involvement with COPD. Why is this important? Well, COPD is the 4th, on some lists, the 3rd leading cause of premature death in the United States. And there's currently robust efforts going on in developing targeted therapy to intercept the progression of lung parenchymal disease and COPD in general. And so there's a hope that drugs of this type will alter the natural history of this process. And we would presume that starting that earlier is going to be associated with a higher possibility of benefit. It has been well known for decades now that lung cancer and COPD are comorbid conditions that routinely occur in heavily tobacco-exposed individuals. So we believe this additional information about COPD in the lung cancer screening context is actually a very, very important public health benefit, an additional public health benefit of screening. And Dr. Rizzo and I wrote an editorial about this in Clinical Imaging that associated the publication of the first report. Next slide, please. So what are the implications of this? COPD is defined by the American Thoracic Society is thought to be airflow obstruction, which may be associated with chronic bronchitis, chronic bronchiolitis, or emphysema. These are three separate findings. And so to an extent, quantitating the extent of bronchitis versus emphysema may be done using different imaging biomarker signatures. And they may be very different from the techniques used to characterize pulmonary nodules for lung cancer screening. So we need to accommodate the imaging acquisition approach without compromising either the imaging for lung cancer or the imaging for COPD. So this requires some kind of technical considerations in how you proceed with this combined analysis of the chest. COPD has a very complex biology. This is very beautifully outlined in an article a few years ago in Oncology by Dr. Javier Zaluta, who is going to be leading one of the sessions on COPD with George Washko. And we'll be hearing more from them later on in this meeting. Next slide, please. So another good thing that's happened over the ensuing years is that there was a major effort between two groups of the Quantitative Imaging Biomarker Alliance, the group from COPD imaging and the group from lung cancer imaging, to integrate their profiles to optimize the quantitative assessment of COVID-19. This effort laid the foundation for harmonizing the technical considerations for both of these diseases in the context of screening, as I just discussed. With the new U.S. Preventive Services Task Force adding about 50% more eligible individuals to the screening pool for lung cancer screening, we'll have now approximately 14 million people eligible for screening. This is an enormous workload. And to do this efficiently, we're going to require standardized, defined efforts to optimize the imaging so that we can learn as much as possible. This is also a wonderful opportunity for pragmatic trials to look at refining the management of lung cancer and COPD conjointly in this integrated effort. Next slide, please. And so finally, we're going to be talking about efforts to improve outcomes if we can find early disease. A big part of that might be lifestyle modifications. And we're going to use the example of physical activity, as we're going to hear in a few minutes from our keynote speaker, Dr. Schmidt. And that's because there's been publications, one that I show here from cancer, showing that physical activity actually is very important in cancer prevention. And two, that physical activity is very important, as shown in a long-term study recently published by the Cardia Group, which included members from the Mass General Pulmonary Imaging Group, led by Dr. Washko, and also Raul Estepar, who's on our steering committee. And this group has shown that long-term studies with cardiovascular fitness show that progression of bronchiectasis is much slower with the group that's more fit than the longitudinal group that was followed that was less physically active. So this is important information for interventions moving forward. Next slide, please. So we're talking about finding pre-symptomatic disease. Why does that matter? Well, again, there's been a recent assessment of general health checks right now in JAMA, which looked at all the current literature and basically distilled that there's only modest at best benefit from an annual physical exam or an annual prevention exam. And so lung cancer screening is going to entail following populations very soon from age 50 onward, which are extraordinary risks for lung cancer, COPD, and heart disease, which is 50% of the premature mortality in our society. Imaging signatures from these people may allow us to see the first evidence of these diseases within a time window in which interventions are still possible. So systematic analysis of this longitudinal imaging experience with computational tools may help us through time identify key drivers of these chronic processes and allow us to bring objective information into this health check conversation and potentially increase the benefit. One potential benefit could be that as we find out that these types of long-term follow-ups are beneficial in terms of health outcomes, we have information that we can share with various communities to potentially overcome hesitancy to participate in these screening services, which is an issue that is well described in the current literature. Next slide, please. This will involve using sophisticated computational tools, artificial intelligence kind of being the buzzword for these types of tools that could allow us to be more efficient, to find earlier signatures of disease. And in the setting of screening, these could be very, very important. However, this is also an area of great sensitivity to many because of concerns about loss of privacy and other issues with AI development. So we have a special obligation, and there's been articles discussing this type of situation in JAMA. I provide a reference below. And we want to potentially avoid biases by various populations that are concerned about or afraid about the use or development of AI tools so that we can have a greater public health impact at a lower cost, with more efficiency, with less harms, and to just improve the screening process overall. This is a big issue, and this will be subject of the discussions from Dr. Yankelevitz and Chris Lathan in the course of the workshop. Next slide. So the fundamental reason why this is so important is because in order to develop the tools, you need to have the experience from all populations that are going to use the tools. And as it's been published, in certain areas where you do have people with hesitancy, their information may not be represented in the tools that are used in the development or the validation of these tools. And one of the most important problems with this in this setting is that the thoracic CT, in addition to lung cancer and COPD, as we've discussed previously in this workshop, can also find heart disease and a variety of other diseases. But this all involves time, because right now it's a manual effort. And in the setting of lung cancer screening, we have challenges with workforce, with the imaging radiologists, clinical radiologists, just to do the lung cancer screening. And we're going to potentially be asking them to use additional tools to do additional efforts. And so that's why developing automated computational tools to do this in a defined time workflow will be very, very important for maturation of this field. And you'll hear more about that. And it's a very important yet potentially sensitive issue. Next slide. I just want to focus on the fact that we're talking about lung cancer, COPD. We could be talking about heart disease. I've provided a couple of references of the importance of thoracic CT imaging for heart disease. And it's so complicated. We didn't want to talk about it this year, but we want to point out that many of the issues that are raised with lung cancer and intersecting with COPD will also be shared with heart disease. And we will come back to this topic in years to come. Next slide. So we're going to have 2 days to discuss all these. Our topics are basically broken into 4 blocks, and you have them in your agendas. And at the end of each day, we're going to have a chance to have breakouts. The first day, we're going to be talking about the issues in 2 different groups. One is going to be talking about the clinical imaging issues with COPD and lung cancer. The second group will be talking about the technical imaging issues between these 2 diseases. And you can choose which of these you want to participate in. We'll have instructions about how to do that when the time comes. Next slide. The second day, we'll take on 2 additional blocks, largely about either the clinical issues or the imaging issues with COPD. And then we'll finish by having a closeout breakout session in which we go through the 2 different sessions together in the full group and talk about potential action items for this workshop. Next slide. What kind of things could emerge? I don't know. It's for the participants to decide, but we could focus on the benefits and harms of lung cancer screening relative to COPD if we embrace this additional information in the screening context. We can endorse the fact that to do COPD and lung cancer screening, we potentially are finding early disease at a time we're not sure what to do with it, but there's certain things such as tobacco cessation and increased physical activity that would have benefit, and we can talk about how to integrate such types of interventions, prevention interventions within the early screening context. Finally, there's opportunities for technical things such as addressing the difference between routine clinical radiologists and automated computational analysis and how that affects handling of the imaging data. And there's some technical things that will be coming up in terms of dealing with that separately, and there's medical legal implications to that, and we'll talk about those things. And then we could also talk about reporting requirements so that we'd get structured reporting so we could develop more systematic management of these new findings. And we might also talk about how do we make the issues with artificial intelligence more approachable to the public so that they can understand the potential benefit and feel better about participating in the development of such public health tools. Final slide, please. So I want to thank all the attendees in advance for entering into this complex conversation. It's an important area of public health. It has practical applications because these are, with lung cancer, COPD, and potentially heart disease, 3 of the 4 leading causes of premature death in our society. We've been working on this for some time. This picture shows a leadership award we gave in 2016 to Lori Fenton, who did inspired work in helping to spearhead the effort to get the national coverage decision for lung cancer screening from CMS 5 years ago. And that was a milestone for this field. And we'll be kind of picking up those threads and continuing to work to try to figure out how to get maximum benefit from these complex imaging processes as an example of moving to much more prevention-oriented population health management. I'll stop there. Thank you very much. So at this point, we would potentially transition to our keynote address. And we're very, very fortunate, as I mentioned briefly, to have Dr. Catherine Schmidt, who is a distinguished professor of public health at Penn State University Medical College and the Penn State Cancer Institute, to help us with a very, very important emerging opportunity in the setting of lung cancer screening potentially. Dr. Schmidt has been working in the areas of physical activity for her entire career. She has been the president of the American College of Sports Medicine. She chairs the Global Exercise is Medicine Governing Committee. She's founded the Moving Through Cancer initiative in the American College of Sports Medicine. She has published more than 260 peer-reviewed science papers and has over $25 million in research funding since 2001. She has led a number of roundtables in the area of exercise for cancer survivor. She has co-chaired the International Multidisciplinary American College of Sports Medicine Researcher and Exercise Professionals. And she has been a driving dynamic force in helping us in understanding the profound impact of physical activity in the cancer context. And so it is with extreme anticipation that I wait to hear Dr. Schmidt's comments as we think about exercise for primary prevention amongst patients receiving lung cancer screening. Thank you, Dr. Schmidt, for helping us today.
Thank you very much. I am hoping somebody can give me a thumbs up that you see my slides and they're in presentation mode. Thank you. All righty. So I spend most of my time thinking about people who've already had a diagnosis of cancer. So Dr. Molsheim and I have had some fantastic conversations over the past several months for me to orient to your particular population. So as an overview of what I'm going to talk about today, we're going to start with talking about what we know what the epidemiology tells us about exercise and prevention of the major chronic diseases, including potentially lung cancer. And I'll make a few comments about what the mechanisms might be that are pertinent, particularly for the conversations that you all will be having today and tomorrow. And then I want to talk a little bit about muscle and the importance of muscle, which matters a lot to patients in overcoming COPD problems, and review the musculature and COPD issues as seen on thoracic CT and how exercise can have an impact on this outcome, and what that might mean for patients that you all see day to day. But then I want to spend about a third to a half of my talk talking about implementation issues. I have been an exercise physiologist since the 90s, and as a result, I'm familiar with the idea that I can tell a group of clinicians that exercise is useful for their patients. And I know that at least some portion of the audience is thinking, yeah, but how is that going to happen? Because it's not a covered entity, and how do we make it happen? So we're going to talk about that. We're going to talk about the issues of the potential for implementation of exercise as a drug for pre-symptomatic COPD, heart disease, and lung cancer. As a source for the first section of my talk today, I am calling heavily on the U.S. Department of Health and Human Services 2018 Physical Activity Guidelines Advisory Committee Scientific Report. So this audience may not be as familiar with the fact that the U.S. Department of Health and Human Services has twice commissioned an expert panel from across the U.S. and a few people from Canada as well to come together to review the scientific evidence base and draw conclusions as to what the science tells us for exercise and prevention and treatment and rehabilitation of a broad variety of health conditions that are relevant to public health. And that scientific evidence base is then used to draw up the most current federal-wide guidelines for physical activity for all Americans, including those with chronic conditions. So one of the slides, and I know this is a little out of focus, but that was the best I could do coming out of that PAGAC scientific report. This is one of, I could have called up 10 different forest plots for you. This is one of many different forest plots about exercise and prevention of cardiovascular mortality. This particular one is about walking exercise and cardiovascular mortality, and it divides it by gender. So there's a section for men and there's a section for women. Interestingly, the answer doesn't differ much between men and women. When we take it all together at the bottom with a great big blue arrow on the bottom right-hand part of the slide, what you can see is a conclusion based on the available evidence base in cohort studies that have been done, that there's a 30% reduced likelihood of CVD mortality for those who are regular walkers compared to those who are not regular walkers. I could have put up a slide that would show you this for swimmers. I could have put it up for joggers, for overall physical activity. This one was just as clear as the others. The evidence is really striking and compelling that exercise has an impact on reducing cardiovascular disease mortality. So this slide actually shows something really cool that I'm going to show you in an idealized form on the next slide. So what we're showing here on the left side is across the bottom of the slide, you can see the different net hours per week, which is just different levels of exercise. And I've translated the net hours per week for you on the right side of the slide. So you can see that there's a vertical line at 8.5 net hours per week, which is translated to 2 hours and 15 minutes of walking per week. And you can see that we have a substantive decline in ischemic stroke and ischemic heart disease, which is just underneath that ischemic stroke line. Almost 10% just from 2 hours and 15 minutes a week of walking. If we increase to looking at what happens at the level of 4 hours and 30 minutes of walking per week, which is not a crazy amount to ask people to do for prevention of these major diseases, we have a nearly 20% reduction in the risk of ischemic heart disease and ischemic stroke, as well as now we start to get to about a 5% decrease in a number of other diseases, including diabetes, colon cancer, and breast cancer. By the time we get out to 9 hours a week, we start to see some really substantive changes. So this particular slide is sort of pointing you to the idea of, well, okay, we want to do more physical activity. How much do I need to do? And my answer will always be, for what outcome? Exercise is a drug. It is a drug like any pharmacologic agent you want to give. As a result, it needs to be dosed. It needs to be dosed appropriately. We don't tell people to go get some chemotherapy. We tell them we're going to give them a very particular drug. We know what the action is of that drug. We give it to them with great specificity in terms of the dose, the body surface area, and the frequency with which we offer the drug. We need to do the same thing with exercise. It needs to be titrated. So this is an idealized version of the same slide that I just showed you. This was actually published in 1994. We've known this a long time. So Dr. Bill Haskell, who was a very well-known exercise physiologist at Stanford, published this theoretical dose response curve, which demonstrates the magnitude of benefit for any given increase in activity. So what we're really showing here, and what is most important to show here, is if across the x-axis at the bottom, you can see baseline physical activity level, and you see with A, we have a very low baseline physical activity level. And if we go from very low to not quite as low, so 10 minutes a day, let's say, of increase in physical activity in somebody who's a couch potato, look at the magnitude of benefit. It's almost vertical. Excuse me, didn't click that. It's almost vertical. On the other hand, if we are marathon runners and we're already doing 5 hours a week of aerobic activity, the increase, the relative impact of doing that extra 10 minutes a day of aerobic activity is very small. This is great news. This means that we get great benefit of physical activity for people who are very sedentary to begin with. Now, what does exercise have to do with, or physical activity have to do with the diseases that you all are particularly interested in? Well, I did find one case control study that was very specifically about COPD and showed that the odds of COPD were lower by more than 25% among the active versus inactive, and that breathlessness was much less common. The odds of breathlessness were lower among the active compared to the inactive. And importantly, this analysis, as you can see underlined in blue, was adjusted for cigarette smoking. But more importantly, perhaps, much larger set of studies were pulled together by a group that does an outstanding job of updating meta-analyses on a regular basis. This is a group out of Canada, and they pulled together the results of all of the cohort studies that had been done to that point, 2016, and all of the case control studies that have been done to the point that they published this, this meta-analysis. And the forest plot, if we look at the bottom of the forest plot, you can see with all studies combined across cohort and case control studies, including one of mine from 2006, you can see a 25% reduced risk of lung cancer among people who are more physically active compared to less physically active. And I'm just so curious. I wish I could sort of ask a question of the audience about whether you're surprised by that information. Anyway, so how would this happen? Why would we believe that there would be an effect of physical activity on lung cancer? And among the mechanisms, the one that I want to focus on today for very specific reasons is chronic inflammation. We have actually so many papers in this area that I've focused on a recent review that was published in this area that shows that if we are regularly physically active, a number of things happen. Things shift in a number of different tissues, including the muscle tissue, the adipose tissue, as well as in the circulation and blood vessels as well. And I want to point out to you the scale at the bottom showing that there is an anti-inflammatory phenotype that is adopted in the physiology of a body that is regularly physically active. But I will also very pointedly show you that in the adipose tissue in particular, as well as in the vessels, we show a decrease in TNF alpha, IL-1, IL-6, and CRP. And I point those out in particular because if we then look at recent trials completed in canakinumab, the left side of this trial is showing the effects of canakinumab on prevention of incidence in patients taking different doses of canakinumab. But what's on the right side of the slide is important in light of what I just said in the last slide. And that is, in a separate paper, these same patients, there were analyses that looked at whether taking canakinumab had an effect on inflammatory factors. And the answer was yes for CRP and yes for IL-6. And these are two of the mechanisms through which we would believe that exercise would have an effect on reducing risk for lung cancer. So in addition to the fact that there is this systemic effect of being more physically active on the inflammatory process and sort of a pro-anti-inflammatory profile in the body systemically, there are a number of other things that happen as a result of being more physically active in anyone, including patients screened for lung disease. The first one being improved use of oxygen. Our arteriovenous difference in the blood is improved as a result of being more physically active. We do a better job of getting the oxygen to let go of the hemoglobin if we are doing regular aerobic exercise. Our energy levels go up, perhaps as a corollary to that AVO2 difference improving. Anxiety and depression are improved, sleep is improved, self-esteem is improved. All of these things are so well documented, it's difficult for me to find randomized controlled trials to show you of these because they've been known for so long. Cardiovascular fitness is obviously improved with regular aerobic exercise, muscular strength with resistance training, and very importantly for the populations that you all are talking about in the next several days, there is improvement in shortness of breath among those who are regularly physically active. We know in the populations that you all are dealing with on a regular basis clinically that muscle matters. Altered body composition is predictive of increasing mortality among COPD patients. And we can look at our thoracic CT scans to measure the muscle area for a number of different muscles that are found in the torso. And the figure on the right side of this slide shows you what survival looks like in patients with different amounts of surface or cross-sectional area, of erector spinae muscles, and clearly showing that patients with more erector spinae cross-sectional area have greater survival. The same can be shown for intercostal muscles and breathlessness. Greater intercostal muscles means better outcomes having to do with breath. Pectoris muscles are also shown in quartiles in mortality on the right side of this slide. What we can clearly see is that the patients who on a CT show greater amounts of pectoralis muscles in that CT survive longer among patients with COPD. Now, this was another place that was interesting for me because I've known, from I can get out my textbooks from the 1990s and tell you that exercise improves inspiratory muscle function. And so it was interesting for me to go find the papers in this area. And you can see that I'm quoting papers here from 1999 and 2002. This is something we've known for a long time. So it's time for us to start to put this into practice. We know that aerobic exercise and aerobic combined with strength exercise improves pectoralis major strength, and on the right side, similarly, improvements in intercostal muscle strength as well. So with all of that in mind, we know exercise would help. We are aware of the fact that exercise would help, but we have, it could be said that in the United States in particular, we tend to think of healthcare as being something that the doctor does for us, as opposed to something that the patient can do for themselves. And so how do we make exercise standard of care? How do we help our patients to help themselves? So the current state of implementation, as I understand it in your field, is that exercise is not standard of care in the setting of pulmonary screening for lung cancer, that a minority of patients are adequately active. And there are probably a multitude of reasons for this. These include lack of awareness by the patients as well as the providers that exercise could be helpful to them, lack of programming, or where there is programming, a lack of awareness of that programming, a lack of referral by the clinicians because of a belief by the clinicians that it isn't their job, that it isn't part of their scope of practice to refer patients to an exercise program. And then the question becomes, well, then whose job is it? There is also, even if we did get all of the patients referred, a lack of a well-trained exercise workforce that understands how to work with this particular population. And finally, we need to understand how to pay for this programming. It probably requires protocolizing it, much like we have with cardiac rehabilitation or with the diabetes prevention program. So let's talk through some of these issues, some of these implementation issues. So these themes, the themes that we see in the area of trying to change clinical practice to add exercise for this population would include certainly policy at a number of different levels, and I'll talk about that. Research issues, workforce development, program development, and stakeholder engagement. I will not have time to go through all of them, but I will point at a few of these. So at the level of policy and funding, at the federal government level or at the third-party payer level, exercise interventions require funding. You can't simply assume that everybody will be able to access and do exercise on a regular basis without there being some kind of infrastructure. I am sure that if I were to query all of the people who are on this webinar right now, that there would be people who are having difficulty finding exercise time in their day and who would benefit from having a structure to make that exercise happen. Not to hold your hand, but perhaps to encourage you on your way. So how do we fund them? The first option would be to have all of the exercise delivered by healthcare professionals. So this would mean sending everybody to a physical therapist or an occupational therapist or a physical medicine rehabilitation doctor. There are possibilities of doing this, and there are patients for whom this is probably the best choice because they are that ill. But there are reasons why that is not a good idea. It would sink the ship with regard to trying to get an appointment. There are too many patients, and it would sink the PT ship. Another possibility would be to change policy so that exercise professionals who are working with clinical populations, like people who are being screened for lung cancer, for them to become healthcare professionals. This is a very, very long road, and there are pitfalls on that road as well. The third option that could be looked at would be to demonstrate that programs are effective in community settings and to change policy to cover the cost of those programs. The example for this would be the diabetes prevention program, which is offered by YMCAs and other private organizations. And the people who are delivering those programs are not healthcare professionals. They are being paid by third-party payers. They are being paid by Medicare and Medicaid, but they are being paid because they are abiding by a set of very particular rules and following a very particular script for how the program is done. This actually might be a way forward for the more well of the patients who come in for screening. Even if we have a program and we're ready to go and everybody's, policies are in place, we have an issue with workforce preparedness, and I'll talk more about that in a minute. And in addition, referrals become a real issue in the area of cardiac rehabilitation and the diabetes prevention program, structured exercise training for peripheral arterial disease, a number of similar sort of programs or sister sort of programs to your situation. Referrals remain low. It's very difficult to get people to go to these programs. And so figuring out how to crack that nut and get referrals to happen is an important thing to do. There are also policies that are likely relevant to this situation at the level of organizations. For example, there may be accrediting bodies for lung cancer screening centers, and their standards may drive behavior. For example, in the setting of cancer care, the ACOS-COC, American College of Surgeons Commission on Cancer, accredits cancer centers, and they say that you have to be asking patients about psychosocial distress, and you need to refer people for care if you find that there's elevated distress. Well, then it happens. That didn't used to happen, and then ACOS-COC decided that it needed to happen, and now it happens. It happens at all cancer centers across the country. So is there something that could be done that would mean that it would be a requirement to recommend or refer patients getting screening for lung cancer to an exercise program in order to improve their health? I'll also note that in my own home organization, we have work to do. Pre-participation guidelines from the Guidelines for Exercise Testing and Prescription. This is a document that is used, rolled over on its 11th edition at this point, used by nurses and physical therapists, occupational therapists, exercise professionals in the clinical setting, all the way down to the YMCA to decide whether somebody should be working out in a clinical setting or in a community setting. Those pre-participation guidelines that are shown on the right side of my slide, I will note to you that they included, well, what do you do with somebody if they have known cardiovascular, metabolic, or renal disease? Well, there's not a word there about pulmonary disease. So even at my own home organization, we need to make some changes because at present, the exercise professional working in a clinical setting does not know how to triage someone appropriately if they have pulmonary disease. We need to do more research. Certainly, there need to be more efficacy trials to understand the benefits of exercise, to improve treatment efficacy, to improve health services outcomes. But I would also submit to this audience that we need to be doing evaluative trials as well, comparing the common implementation models, whether we should be doing counseling for these patients and sending them on their way, individual training, group training, which one of these is the best model and most cost-effective model for us to move forward. There also needs to be work in the area of implementation science for us to understand how best to change clinical care so that clinicians working in this area understand who to turn to and how to press the easy button to make an exercise program happen for these patients. As an example of this, you could start with patients screened for lung cancer with CT scans. You would randomize these patients by clinic. So this is a cluster randomized trial. And you would randomize within clinic to a standard arm where everybody would be getting brochure therapy, which we have documented doesn't work, by the way. So handing people a brochure is not enough, as opposed to implementing an exercise as medicine approach where you would facilitate implementation to adapt a clinical workflow so that you would enable patient assessment, advice, referral, and connection to an evidence-based exercise intervention. By doing this, you would be addressing an existing gap in testing effective implementation strategies for improving physician referrals and utilization of evidence-based exercise interventions in the setting of lung cancer screening clinics. We know that this evidence base exists for short behavioral interventions, referrals, and treatment, in primary care, but there is a gap in the setting of lung cancer screening clinics. It's also really, really important that we do this work in the setting of community clinics and not just in academic clinics. And the reason for that is that it's important to study real-world factors that influence implementation. This is, of course, a multi-level intervention. The first level of intervention is something that we think of when we think of randomized controlled trials, and that's the level of patient. That's the evidence-based exercise intervention. But there also needs to be an intervention at the level of the treating clinician and the care delivery team. There needs to be a change in how the clinic is doing business in order to change getting exercise to be a part of the clinic flow. Specific aims of a trial like this could be to assess whether or not doing this implementation facilitation, this implementation work actually increases the proportion of patients that actually get referred to an exercise program. And the second aim would be an implementation aim to see what the mechanisms are. for making that happen? What are the, what's making the gears turn? And then the third aim is about the effectiveness of the actual patient intervention itself. There is, of course, a need for workforce development. Again, if we were to get all the money in the world and all the policies in the world to happen tomorrow for this, we still don't have a workforce that is ready to work with lung cancer screening patients. We need to identify the knowledge, skills, and abilities that are necessary in exercise professionals to work with lung cancer screening patients, and probably rebuild some kind of credentialing tool at an organization like the American College of Sports Medicine, and perhaps create something like a one-on-one module. My reasoning there is that it is likely that there is a great broad variety of impairment in these patients. And in the same way that you don't need every YMCA floor trainer to be ready to do cardiac rehabilitation, but they all need to know how to do CPR. And they need to be able to screen people and say, you shouldn't be here, you should be at cardiac rehabilitation. We need people to know when they should stop working with somebody and send them to a more clinical setting. And that's what that one-on-one module would be about. Finally, there needs to be program development. We need to identify the places around the country where programs already exist. There are likely exercise programs that are exemplar programs. Map them, figure out where they are, who has them, why do they have them, and somebody else doesn't. Enlist a national fitness chain to perhaps start pulmonary specific programs. There are enough Americans around that have this issue that they may actually make a buck on it. And finally, by mapping them, you can help existing programs to spread. So what I'm concluding here is that in order for you to take the evidence base about exercise and pulmonary disease and translate it into clinical practice, there is an entire field of research that needs to happen in implementation science for that to all shift. It relates to policy, stakeholder awareness, program development, workforce development, and research. Thank you very much.
Thank you so much, Dr. Schmidt. That was wonderful and incredibly relevant to our workshop discussions. I've already seen a question from Bruce Byenson regarding your presentation. Bruce, do you want to talk about that?
Thank you, Jim, and thank you very much, Dr. Schmidt's wonderful presentation. There's some prominent organizations that are in the wellness space, or used to be called disease management space. The examples of those organizations are Livongo or Unduo, which is a subsidiary of Google, I think, and those organizations sell programs to employers for as part of benefits program or to insurers for the insured populations. I'm wondering if you have a perspective on the effectiveness of those programs for the kind, given the evidence that you presented and the compelling results. Welcome hearing your thoughts on that.
Yeah, I actually think that has worked quite well for the diabetes prevention program. And I think that one of the things that I think has gone well with that is that payers are able to hold those companies and others like them, hold them to standards. If they only get paid if the patient shows up more than 5 times, and they get paid more if the patient loses 7% of their body weight or something. So they're very outcomes oriented, and they're held to a much higher standard than most of the rest of healthcare. By the way, I love that idea.
Thank you very much.
Thank you. There was wonderful opportunities from your description of changes in the musculature as a function of fitness and whatnot. Dr. Yankelevitz, who is an imager, as you well know, has some questions, I think, in that regard.
Yes.
Hi, Catherine. Actually, Jim, I had a couple of questions. First, as a comment, I really appreciate the idea of thinking about exercises in terms of being a drug and thinking of dose. That's really I hadn't heard that before, and I appreciate that. And I do have a question about how you decide the dose, given, that's one question. And then the other thing I just was hoping you could comment on, since a lot of this is about lung cancer, I know there's been a fair amount of work on the benefit of exercise in cancer patients, and in particular, both in predicting prognosis, looking at the general health of a person and exercise, preventing recurrence, and also potentially in, sort of treating disease. But since we're a stage 1 group that we focus on early lung cancer,
Yeah.
How do patients that get lung cancer, preventing recurrence, how well they do, that sort of thing. Do you have anything that you might add to that?
Sure. So let me answer your first question first, because it's an important one. And your question was about how do you figure out the dose? And the answer is in dose finding studies. And those studies exist, and we are able to titrate and understand how much exercise we need to do for a broad variety of different outcomes. And the roundtable that I spearheaded for the American College of Sports Medicine on exercise and cancer prevention and control was able to conclude that we had sufficient evidence to give a what we call a fit prescription, which is frequency, intensity, time, and type, which is about as exacting a dose as you can get for 8 different cancer health related outcomes for people who are going through treatment and soon after treatment. So those studies do exist. And if they don't, then that needs to happen for you to figure out exactly how much to titrate. And I would submit that we go for maximum tolerated dose, right, in a drug study. With exercise we kind of turn it upside down, because exercise is like broccoli. Nobody wants to do it. So we've got to figure out the minimally effective dose. Because that's what people are willing to do. But your second question was about what we know about the benefits of exercise in early stage lung cancer. And the answer is really little, really little. That is actually an area that is very ripe for additional research, because we have no reason to believe that the benefits, the 8 cancer health related outcomes that are better during and after treatment, those data are available, based on studies that have been done in colorectal cancer and breast cancer and prostate cancer and many of the more common cancers. But there is absolutely no reason to believe that it wouldn't be true in early stage lung cancer as well. But sure would be better to do those studies, even if it's a demonstration project, just to say, yep, it's the same. Okay.
Do you have other people that have questions?
Yeah, this is Al Rizzo. Dr. Schmidt, thank you very much for your presentation. I'm a pulmonologist and I work a lot with the American Lung Association. And quite honestly, since 1980s, we know that pulmonary rehab has been shown scientifically to benefit patients with COPD. And we have had the fight with really the third-party payers, the government, to try to get pulmonary rehab supported to the level that it needs to be. I mean, the amount of money they throw at it doesn't allow for centers to be up and running, doesn't allow for the staff that you're talking about.
Yep.
So I'm glad you're going to add something to your sports medicine thing about pulmonary that you mentioned that would help. And I'm curious as to whether you've ever been enlisted to be on some of the advocacy teams to address the issues about the importance of exercise and lung disease, particularly pulmonary rehab.
Not yet, but I have a feeling I'm about to be enlisted.
Well, yeah, we work a lot with the AACVPR about pulmonary rehab and cardiac rehab, and we just keep hitting a brick wall. So I'll look forward to maybe connecting with you and seeing what other ideas you may have, because this is just frustrating for the patients, it's frustrating for the physicians, and therefore the referrals don't take place because we know it's not going to happen. It's not paid.
Yeah.
So you hit all the topics.
I suspect that, and this was exactly Jim Mulshine's nefarious idea to get me involved here.
Correct.
So he's like, what? I don't know. Anyway, so Dr. Rizzo, I based on my reading of the literature, I suspect that exercise for cancer patients during treatment is in a very similar place to exercise for pulmonary patients. And that is that we have this gorgeous evidence base, and yet it doesn't happen. And so there is a need to shift our attention so that, you know, if they're not paying for it, or they're not paying for it sufficiently, then we need to give them a different kind of evidence. There's clearly a need to shift so that we're focusing on this implementation science and health services research. And I've thought that that was the case for pulmonary disease and exercise for a long time. So I'm in. Count me in.
Great, thank you.
Am I allowed to call you Bo too?
I was, yes, please. Anyway, so that was a great presentation. It really, really highlighted some of the things this foundation has been saying for years, although we haven't been specific to cancer patients. We've been more about the benefit of exercise when it comes to primary prevention. But what I wonder in practical terms is whether the group of lung screening centers that participate in the GoTo Foundation's Centers of Excellence program that have been certified as Centers of Excellence, and there are 900 of them around the country, if there could somehow be a demonstration project, that's something this foundation could consider funding within a certain.
And it could be virtual. It doesn't need to be in person.
Mhm.
We now because of COVID, I mean, the gift of COVID, dare I say
Even
that?
better.
Is that, you know, we all are understanding that we can be with each other virtually. And
Mhm.
most of my trials, even, you know, particularly like I do work in metastatic breast, and we're not seeing those in person. They're at risk,
Sure.
you know. So we're doing a lot of exercise trials virtually, and I think that there is a lot of room for that. So I'd be very, very interested in talking to you further.
Well, we should talk to Laurie Fenton Ambrose and see if there would be any interest in the GoTo Foundation's part in doing some sort of demonstration project. I don't think that there's an exercise component required for one of their centers to be certified as a center of excellence. So
Right.
it seems like, but you've got a group of screening centers that we know are doing a good job, and they've
Yeah,
passed.
would be interesting to start with a survey of those centers to find out who's doing exercise.
It would be. It would be. Well, but that's a next step, isn't it, Jim? Between now and next year,
Yeah,
next week.
that's right.
Thank you.
Absolutely.
Yeah, Catherine, I think this is a wonderful set of discussion that emerged. One thing I would caution though is Bo talked about this as a preventive service, and I think in the setting of screening, where we potentially screen 100 people, one of them on a given year may have lung cancer, and so in a sense, it's better. We need a new term for people participating in screening. They're not really patients. They don't have a disease. They have a risk of the disease, and the concern is that they would start thinking themselves as patients, and that's the kind of antithetical to what we're trying to accomplish. We want them to be healthy people, and with the risk that we can manage the risk. And so there's a whole.
Yeah, as a corollary, I'm on the standards committee for the National Accreditation Program for Breast Centers, and I am advocating pretty vigorously for the idea that women who come in for a mammogram should be given something that tells them what else they can be doing to reduce their risk of breast cancer. And so we have that now in standards. That's going to be rolled out next year. So could we? I mean, I'd be delighted to hand the same thing to you all, because the risk reduction guidelines are risk reduction guidelines regardless of, there's quit smoking, get a healthy weight, exercise, eat a healthy diet, they're the things that I think everybody on this call knows, right? But ACS has produced beautiful graphic things that could be handed. I mean, we need to do more than, you have to do more than hand a piece of paper to people, but handing a piece of paper to people is a start. By virtue of the centers doing screening, handing a piece of paper, the centers acknowledge the importance of the patient's behavior to their own health. Just simply by virtue of getting them to do that, it's a step. It's a step towards having a program.
Yeah, so we should do, ACS is the sponsor of this workshop, and we should follow up with them as well. So we have action items for both them and GoTo Foundation. It was interesting, your comments on the biomarkers of inflammation that were modified by exercise and how they overlap with the intermediate endpoints that they used in the CANTOS trial that you described. And I understand from some of the discussion of that, and George Washko will be with us later, one of the concerns was that the imaging done in the setting of that cardiovascular and lung cancer secondary endpoint trial were not specific towards COPD, so that if there was a benefit of modifying those inflammatory mediators, it wasn't necessarily appreciated in the lung parenchymal imaging, because the lung parenchymal imaging wasn't done with a clear definition of what's good and what's bad. And it kind of reflects the state of the art in lung cancer imaging, that we can tighten up stuff so that the experimental signatures can be reduced into clinical practices. And we'll have more comment on that. But again, the issue of trying to figure out if in a particular individual, if we could map the state of their various muscle groups, potentially their fat depositions and other body composition factors from the quantitative imaging, and have a snapshot on an annual basis and say, Mrs. Jones, you're doing a great job with your exercise program and your fitness profile, along the lines of what we use for a BMI, but the BMI doesn't work because it's too non-specific, whereas we have this possibility with the imaging profile to be much more tailored in giving a meaningful objective basis for whether their dose of their exercise drug is not sufficient or insufficient or being followed closely enough. I think that would be very helpful in a clinical setting for a whole variety of reasons. David, do you want to comment on that? You've done some background work in that regard from your group, right?
Yes, we have, and there's a lot we can measure. There are a lot of indicators of muscle mass, muscle quality, fat quality, and potentially, even more that we can do. So this would be of some interest, and especially in the screening context where you are bringing people back at annual intervals, you can look at change over time. I don't know. I was curious though, Catherine, how do you measure progress? How do you measure whether people are progressing in terms of their exercise? Do you measure sequentially levels of inflammatory markers, that sort of thing?
No, we look at pretty gross measures of physical function tests. I actually, over time, have migrated away from doing structured exercise testing because of, what I get from it clinically is not so much better than doing a short physical performance battery, a 6-minute walk test, chair stands, those kinds of functional tests, and then body composition. We know the body composition changes as a result. I mean, if we have,
how do you measure body composition? What's your
our preferred
traditional
measure
technique?
for in the clinical setting is DEXA, and I understand the limitations of DEXA, but that's what we use.
Just one other question. Usually when people talk exercise, they talk a lot about diet, and I noticed in your talk you didn't focus so much on diet.
Right.
Especially, and even in the context of lung cancer. I know this is all very controversial, things like diet, and how that impacts, but emphysema or lung cancer. How much weight do you give to the role of diet and the impact of diet in some of these areas?
Yeah, so it's a tricky thing for me to talk about because I know what the science says. And at the same time, I'm not a nutritionist. So I'm an exercise physiologist. So what I can tell you is that the science on the effect of exercise on the pulmonary system and systemically in ways that are relevant to the pulmonary systems, the cardiovascular system, and musculoskeletal system is deep and profound. And what we know is relevant clinically and actionable right now. But you don't have to exercise. You can go your whole life and not exercise, right? But meanwhile, you do have to eat, right? So you actually do have to eat. And so people do want some kind of guidance about their food. But the scientific evidence base about the effectiveness of various different diets on pulmonary outcomes, musculoskeletal and cardiovascular outcomes is not as robust as it is for exercise, in part because it's more complex. I'm not criticizing my colleagues. It's just harder to do because there's so many more variables. I think that what we are able to really kind of, put our thumb down on and say, yep, we know this, is more fruits and vegetables, limit red meat, and generally avoiding saturated fats. What we know is relatively small, and we don't know, we're not able to do the dosing. Diet is a medicine like exercise, but our ability to dose it, we're not there. We're just not there. Sorry.
Do you have any more?
Any other questions? Bruce? Okay. We have a question from Stephen Lamb. Are there nomograms for erector, spinalis, pectoralis, and intercostal muscles? Does that
No.
make sense?
No, but that could, based on what David's got, I think it could be developed.
Yeah.
That's provocative.
And that would be very important normative information in terms of developing an annual fitness type of thing. One of the questions that emerged in my mind relative to, so you have a motivated individual and they get in an exercise program and they're doing structured exercise, however it's defined. I gotta believe that that person might be a more appropriate candidate for tobacco cessation efforts, because they're starting to focus on their health and realizing the implications. And in general, athletes smoking is not as prevalent as non-athlete smoking and this, that, and the. Have you ever thought about that relative to your work with cancer patients?
Yeah, I actually thought of doing this as my dissertation. It's just so funny because this is something that's like been in my head for a long time. Harry Landau is a tobacco researcher at the University of Minnesota where I did my dissertation. And I was interested in this idea. What we noticed in the heritage family exercise study was that the smokers shifted who were instead, they had to come in 3 times a week and do really high intensity exercise 3 times a week for increasing amounts of time over 20 weeks. And what we noticed was that the smokers changed their practice of smoking and their timing of their smoking according to when they were going to exercise. They would avoid smoking prior to doing an intense exercise session because it was so uncomfortable, right? So I was just fascinated by that. I thought, that would be very interesting. There has been one successful pilot that looked at physical activity for smoking cessation that went very well, and then they did the fully powered trial, and it did not go well because they couldn't get people to do and this was interesting to me in light of my observation all those years ago, they couldn't get people to do the vigorous intensity activity.
They couldn't do what?
Vigorous, they couldn't get them to do vigorous, high intensity activity. So, I think that I think that it's an issue that could use some more attention.
Okay.
But I think it needs to get attention at a level of like, you know, a pilot and some qualitative work, you know, at this point to understand what smokers are willing to do. I think, yeah, I think it's worth chasing.
Okay, well, thank you so much. And we have to conclude now, but it has been so wonderful hearing your thoughts on this very, very important subject and important opportunity. And we will follow up with suggestions that we just discussed. So thank you, Catherine, for a wonderful keynote presentation.
Well, thank you so much for the invitation, and I hope that the rest of the time together is productive. Maybe I'll be back to present some results next year.
We look forward to that.
Okay, all right.
Thanks.
Okay, bye-bye.
Okay, thank you, Catherine. And so we now move on. This is, I don't know why, but this is one of my favorite parts of the workshop. We're next going to invite all the participants in the workshop to listen to the National Leadership Award ceremony, which we recorded in person earlier this month. Afterwards, we'll go to a short break, and you'll see you back here at 11:15 after the ceremony for session 2. So now we go on to a very, very special recording for recognition for a very important contribution to the field of screening.
First, I want to thank Carolyn Aldeget, or we call her Bo, and the Prevent Cancer Foundation for creating the James L. Mulshine Leadership Award, which recognizes the guidance and leadership that James Mulshine has provided over many years. I have known Jim since 1999, when I first met him and he introduced me to Bo. They have both been extremely important in moving screening forward and very supportive of our entire screening team. I want to use this opportunity to thank them, as I cannot really truly express how much that meant to us. The 8 James L. Mulshine Leadership Awards have demonstrated the broad scope and vision of their joint leadership. I have been honored to have been a recipient of this award, which I treasure. Actually, it's standing right there, and it inspires me every day. So it is a great honor and privilege to present the 9th James L. Mulshine Leadership Award to Dr. Mary Pasquinelli. Mary has been a practicing nurse since 1985. During that time, she stayed deeply involved in strategic scholarship issues, which culminated in her receiving a doctorate in nursing practice from the University of Illinois at the Chicago College of Nursing in 2018. Dr. Pasquinelli initially provided care for people having bone marrow transplants and HIV disease, and saw the importance of providing outstanding health care in a diverse and often disadvantaged community setting. In 2015, she became the principal investigator of an IRB-approved study on health disparities assessment in the lung cancer screening program, which she established at the University of Illinois Medical Center. This study reflects her longstanding interest in health outcomes in challenging settings, including lung cancer screening. She has consistently focused her attention to addressing health disparities. Currently, she serves as the director of the lung cancer screening program and as a nurse practitioner for the pulmonary and medical oncology for lung cancer service line at the University of Illinois Hospital. The University of Illinois Screening Center is housed in a federally qualified health center and serves an underserved community in the Chicago urban environment, principally composed of African Americans. She's also developed dedicated lung nodule clinic, which evaluates pulmonary patients who are at high risk of lung cancer and provides clinical care to medical oncology patients diagnosed with lung cancer. Mary's work is particularly meaningful to me on a personal note. I received my medical degree from Howard Medical School in Washington, D.C., and trained at DC General. I first saw, or I really saw at firsthand, the need for such efforts, and I congratulate Dr. Pasquinelli for her tenacious and impactful efforts in this area. Lung cancer is the #1 cancer killer, and I'm paraphrasing a quote from James Mulshine, who described lung cancer screening as the most significant curative breakthrough in modern time in the war on cancer. However, the remarkable potential of this new screening service will not be realized without the remarkable efforts of people like Mary, who are now on the front lines of making this happen. Her efforts in lung cancer screenings demonstrates to me convincingly that CT screening for lung cancer is here to stay. Given the growing momentum of this service, I'm confident that lung cancer screening will now achieve the widespread implementation to truly achieve the early cures that it can provide. When my team started back in 1992, it looked like an almost fanciful oddity. Fortunately, after our 1999 Lancet publication, there was a great surge of hope for increasing the prospects of lung cancer cures. But this was followed by a tremendous pushback. Even after the publication of the definitive randomized trials in the US, the National Lung Screening Trial and the Nelson Trial in Europe, both of which definitively confirmed our screening results, the national uptake of lung cancer screening has been dismal. The naysayers are still actively discouraging national screening uptake. However, while barriers against screening have been strong, I now see real hope for a much more rapid implementation of screening because people like Mary are there to work on this, and I will tell you why. Dr. Pasquinelli represents the front line of lung cancer screening as she's bringing this life-saving screening to underprivileged people at risk of lung cancer. She works directly in communities of underserved individuals, and she has a true knowledge of their problems in working within that academic center. She's published papers that pragmatically address the bottleneck issues. It is this type of work from people who've actually lived these experiences that ultimately overcome screening hesitancy and will have the great impact in reducing lung cancer deaths. Further, Mary approaches her work with a global perspective as she routinely works with groups across the world, including Cambodia, Haiti, Guatemala, Tanzania, and India, and probably many more that I am not aware of. Such international collaborations have always been very close to my heart, as I think it is very important to share innovations and challenges throughout the world. In her position as a nurse practitioner, Mary has run a screening program. She provides substantive input to various local, national, and international healthcare organizations, as she has deep firsthand knowledge of the issues of women and minorities in regard to lung cancer screening. She understands that the growing participation of lung cancer screening, especially in medical underserved communities, is currently the biggest challenge. This is a particularly sensitive public health issue and challenge for this tobacco-related disease, given the long history of predatory tobacco marketing in the very same communities. This reality was indelibly sketched in my mind after hearing Sharon Eubanks recount her experience in leading the prosecution of Philip Morris versus the United States at this same workshop in 2018, when Sharon received her leadership award. However, Mary's impact extends beyond developing and running a busy and successful screening service, as she has also published 5 important papers and given many talks about the screening experience, with special emphasis to addressing health equity for this new cancer screening test. Her work and leadership also highlights the efforts of screening champions throughout the US and the world who are working to overcome fear, misinformation, and indifference to bring lung cancer screening services to the vast populations of individuals who are or used to smoke. These individuals all share the high risk of lung cancer throughout their lifetime as they remain at elevated risk and then die of lung cancer. We now definitively know that lung cancer screening can change this dreadful fate. Medical professionals like Mary are succeeding against all odds in bringing the service forward. Lung cancer is the leading cancer killer across the globe. And as I mentioned earlier, some consider lung cancer screening as the most significant breakthrough in modern time in the war on cancer. However, this potential will not be realized without the work of people like Mary, who are essential and are on the front lines delivering the service even to the most vulnerable populations, while continuing research to further refine the process and enable even greater benefit from screening in the future. Congratulations, Mary. It means a lot to me. Thank you.
My name is Jim Mulshine. This is a special day for me as well as for others. And I just wanted to give you a little background. This is a workshop that we started 18 years ago with the Prevent Cancer Foundation. The original group starting this included myself, Rick Avila, David Yankelevitz, Stefan Schaller, and we were focused on integration of quantitative imaging into improving the process of lung cancer screening. And after the first couple of years, it became obvious that to do this right, we had to involve a lot of other communities, because there were many aspects of screening, including who should we screen, how do we do it best, what is the management, how do we relate to the surgical intervention, and all kinds of other things, especially in terms of making sure that the people that needed it most knew about this service and were comfortable participating. And so we very shortly realized that the key thing to this was to get the leading thought leaders involved in a very intense multidisciplinary conversation on this annual basis to just say where we are and what the big challenges were and what we could do about them working as a group. And so as this moved forward, it became very clear that individuals were doing extraordinary things in this field. And about 9 years ago, actually 9 years ago exactly, Bo came up with the idea that we should do a leadership award. Now, for reasons that kind of elude me, I got to be the named person for this award. And it's been a great honor. And we've had enormous amounts of fun trying to identify individuals that really have contributed in profound ways to the transformation of this field. And so we continue this legacy now. And we just heard from Claudia some amazing things about what Mary has brought to the field of lung cancer screening. So I'm delighted to be here. And this is yet another example of somebody who's made an enormous difference to the betterment of our society.
Thank you, Claudia. Your remarks were incredibly gracious, and we really appreciate your acknowledging the value of our workshop. But this workshop would never have happened without you and David and your team and the seminal work you did to ensure that lung cancer screening would become a national program in this country. And I think it's really important to point out that these quantitative images capture not only lung cancer, but also detect early COPD and early events that lead to cardiovascular disease. So this way, you get a CT scan, you get a threefer. And I think it's really important that we not lose track of that fact. And in mentioning that, I'd like to also acknowledge the American Lung Association, which has partnered with us on this workshop now for the second year. I'm going to lead off with two of my very favorite quotes because the Prevent Cancer Foundation has long been engaged in the issue of health equity. And since the late 80s, when we stood up our very first program addressing inequality in healthcare, I have often referred to this quote by the Reverend Dr. Martin Luther King, who said, "Of all forms of discrimination and inequalities, injustice in health is the most shocking and inhuman." And the second one I want to mention is my birthday mate, Mahatma Gandhi, who said, "Be the change you want to see in the world." And the reason I bring these both up is because this is what Mary Pasquinelli is doing every single day. She is being the change we all want to see in the world by bringing equity in healthcare to some of the most vulnerable patient communities in the city of Chicago. And it's my honor and privilege to present the James L. Mulshine, MD Leadership Award to Dr. Mary Pasquinelli.
Thank you. Thank you, Dr. Mulshine, Carolyn Aldoget, and the Prevent Cancer Quantitative Imaging Steering Committee. I was stunned when Dr. Mulshine called me to tell me that I was this year's recipient of the James L. Mulshine National Leadership Award. It took some time for this to sink in. I'm incredibly honored and humbled to receive this award. As a nurse practitioner, this award is very meaningful to me, as many nurse practitioners are now taking active leadership roles in the developing of lung cancer and early detection programs. Dr. Henschke, thank you for your kind remarks. You are truly one of the pioneers of this field and have paved the way for me and for many others to make a difference by use of CT imaging to improve health outcomes. In 2015, a few months after I was hired by the University of Illinois at Chicago with the goal of developing their lung cancer screening program, I was encouraged by a colleague to attend the Prevent Cancer Quantitative Imaging Workshop. This workshop highlighted the power of what CT imaging can achieve and the impact imaging can have on the early detection of tobacco-related diseases. Attending this workshop has given me the opportunity to network with some amazing people and gain knowledge that I have taken back to our university, which has contributed to the overall success of our program. During the evolution of our lung screening program, including the development of an incidental nodule clinic and a multidisciplinary thoracic oncology clinic, we identified racial and ethnic disparities in lung cancer screening. Not only did we see this as a health disparity, but we saw this as a social injustice. To address this problem, we took a deep dive into understanding our lung cancer screening and lung cancer population, and our published research on health disparities added to the growing evidence that race and gender disparities in lung cancer screening criteria exist, and lung cancer screening criteria needs to be refined. We are constantly working to improve our program and to optimize the ability to use the results of the low-dose CT as a teachable moment to help our patients understand the health of their lungs and to provide personalized care to decrease their risk of tobacco-related diseases. Dr. Mulshine, you are a true visionary. Your leadership and the work of this committee must be commended. At this workshop, the latest advances on imaging technology are discussed, from novel tools to assess image distortion, quality improvement initiatives, and forming a global collaboration to share and analyze low-dose CT images worldwide with the use of machine learning. Dr. Henschke and the ILCAP collaborative research team advances our knowledge regarding nodule characteristics, volume doubling time, algorithms to decrease false positive rates, optimization of screening intervals, and survival outcomes. This information has been vital to the evolution of screening practices. In addition, the multidisciplinary framework of this nodule highlights the importance of public policy, advocacy, population health, equity, and financial analysis to better understand the impact of lung screening. The work that the Prevent Cancer Foundation has done, from workshops, grants, research, and education, has been incredibly valuable. I want to tell you that the lung screening community is listening and acting. We are collaborating and sharing best practices. We are translating research to clinical knowledge to improve lung screening programs and outcomes. We are conducting research. We are reaching out to vulnerable communities and populations and forming community partnerships. And we work to overcome barriers to improve access to connect high-risk individuals into screening programs. I want to thank my multidisciplinary team at the University of Illinois at Chicago, who has supported and guided our work. I want to thank my co-authors on our published work, specifically Dr. Lawrence Feldman, Dr. Kevin Kovitz, and Dr. Martin Tamamagi for their guidance and mentorship. I want to thank our patients who put their trust in us every day. And finally, I want to sincerely thank the Prevent Cancer Foundation for recognizing and supporting our work. Thank you very much.